A young man appeared at the emergency room of a large city hospital following a gang fight in a downtown ghetto. He had suffered a deep knife wound at the anteromedial aspect of the right forearm. Okay, Mr. Lipschitz.
Please, call me Porkchop.
Okay, Mr. Porkchops. You are to return in 1 week for an examination and to have your stitches removed.
No problem.
He neglected this advice. However, when the skin around the wound became inflamed and began to itch, he removed the sutures with his own knife. The inflammation subsided, and he went about his business, but he soon recognized that his right hand didn't work anymore as well as it used to. He noticed that his hand had assumed somewhat the look of a claw, with exaggerated extension of the metacarpophalangeal joints and flexion of the interphalangeal joints, primarily the two middle fingers. The fingers could not be abducted or adducted, and adduction of the thumb was lost. When he attempted to pick up a piece of paper between thumb and index finger, the thumb would assume a hyperflexed position in the interphalangeal joint. This is known as Froment's sign or Froment's paper sign, and it is characteristic of this disorder. In addition to these problems, the patient noticed sensory loss over the medial aspect of the palm and dorsum of the hand, and on the front of the ring and little fingers, and on the back of the medial 2.5 fingers. He did not seek medical attention. The structure that was injured was the ulnar nerve, and the condition it produced is known as claw hand. In some individuals, the symptom of the medial 2 fingers are exaggerated, and when the index and middle fingers are normally extended, the result has been referred to as the hand of benediction. The ulnar nerve is one of the terminal branches of the medial cord of the brachial plexus. It descends in the arm, in which it has no branches, medial initially to the axillary artery and later to its continuation, the brachial artery. It descends over the medial head of the triceps and then occupies the groove on the back of the medial epicondyle of the humerus. At this point, it is superficial in position, being susceptible to blows. We speak of hitting the funny or crazy bone or to injury. After giving a twig to the elbow joint, it enters the forearm by passing 2 heads of the flexor carpi ulnaris muscle, both of which it supplies. It then comes to lie on the medial half of the flexor digitorum profundus muscle, this portion of which it also supplies. The ulnar artery accompanies the nerve in this part of its course, but was not apparently cut, as demonstrated by the lack of severe bleeding at the injury site. The nerve then enters the palm by crossing superficial to the flexor retinaculum. At about the distal border of this structure, it divides into superficial and deep branches. The superficial branch gives a twig to the palmaris brevis muscle, and then supplies the medial aspect of the palm and medial 1.5 fingers with sensory branches. The deep branch descends through the hypothenar muscle, which it supplies, deeply into the palm to accompany the deep palmar arterial arch. In this position, it supplies all of the interosseous muscles, the 3rd and 4th lumbricals, the adductor pollicis, and the deep head of the flexor pollicis brevis muscle. The dorsal interosseous muscles abduct the fingers away from the plane of the middle finger, whereas the palmar interossei adduct them. A useful mnemonic device for the functions of these muscles is DAB for dorsal, abduct, and PAD for palmar, adduct. Denervation of these muscles explains the loss of these actions. The intrinsic muscles of the little finger, hypothenar, are the abductor digiti minimi, the flexor digiti minimi, and the opponens digiti minimi. Their names imply their actions, which also were lost in the young man's case. Similarly, adduction of the thumb was lost and flexion of the thumb was weakened. The denervation of the medial 2 lumbrical muscles is the key to explaining the clawing of the hand. Denervation of these muscles explains the exaggerated extension of the metacarpophalangeal joint and the flexion of the interphalangeal joints. The disorder was permanent and was responsible for a physical deferment from military service, as well as causing him great difficulty in handling manual labor jobs thereafter.